Hello, everyone. My name is Tanya Penaflor. I'm going to be doing my quality management Pdsa project on behalf of California State University, San Marcos for my Nurse 451, the Leadership and Management Laboratory. This project is based off the Pdsa model, which was first introduced by Walter Stewart. This model is based off a systematic series of steps that are used to gain valuable learning knowledge for continued improvement. For the issue identification, I'm going to be focusing on healthcare-associated infections. More particularly, I'm going to be focusing on Clostridium difficile, also known as C. difficile, C. diff. Here are some facts that I got from the CDC. My references are listed on each corner. For the facts, in 2011, C. diff was responsible for almost 500,000 hospital-associated infections in the U.S. 29,000 died within 30 days of the initial diagnosis. Patients greater than 65 years of age, 1 in 11 died of healthcare-associated C. diff within 1 month of receiving diagnosis and treatment. More than 80% of C. diff deaths occur in patients greater than 65 years old. C. diff is the leading cause of hospital-associated gastrointestinal infections and illnesses. Approximately $3.2 billion are spent on C. diff alone annually. That was in 2013. Now that might be a bit higher. So for risk factors, the risk factors that I found, hospitals and long-term care clinics, if you're a patient there, anyone 65 years of age or older, a person undergoing abdominal surgery, a person having existing GI issues or disorders such as IBD or colon cancer, patients with immunosuppression, being that it be cancer, HIV, etc. A previous C. diff infection or recent infection, treatment with acid-reducing medications. So what is C. difficile? We all know it's, as nurses, C. diff, we think isolation, right? So it's a motile anaerobic intestinal bacterium that form spores. And as we know, if you remember from microbiology, spores are really hard to get rid of. C. diff produces 2 toxins known as toxin A and B, and also an enzyme. It is considered an opportunistic pathogen with when used with broad spectrum antimicrobial drugs such as penicillin and cephalosporin. So what does C. diff do to the gut? Here's a picture that I got from Padlock. 24 hours after exposure, cells of a colon lining are normal. This shows the 30 hours after exposure. It shows the toxin and the damage that it's causing in the gut, inflammation, fluid buildup. And 36 hours after exposure, you have inflamed cells that burst and die. C. difficile spores then leave the colon via the diarrhea. Okay. I included methods of diagnosis because I think it's important. Stool collection. This is something I did not know. Stool must be taken and sent down to the lab within 2 hours or refrigerated, because if not, the toxins begin to degrade in room temperature. So it's important to let ancillary staff know, hey, I'm going to be collecting for C. diff, just so it's not sitting in the room and you don't know. So it can be a correct result. Oh, jumped ahead here. Okay, so rule of thumb, if you can stick a toothpick in it and it stands, don't send. This is what I've always been told at work. So it's been a little like, well, the toothpick cleans over. So that's what we're going to talk about, okay? Because it's a lot of uncertainty with stool collection. For tests, there's the EIA, the tissue cytotoxin assay, toxigenic culture. The EIA is the most common. The thing, it's fast and easy, but it has poor sensitivity. The one that's used in my workplace is called the two-step paradigm. They use 2 tests to kind of test one and then the other. I was told it tests for toxins at first and then for antigens. Okay. So that's how they test for C. diff. This is actually a report that I got from my infectious disease manager at my workplace. It shows my unit, South 3, which is the cardiovascular tele unit. It shows the report on the second quarter of 2007. So we had 5 C. diff cases, which is way above the standardized infection ratio. Goal is less than 1, and we were well over that. So I thought I'd share that. For quality variance, so like I mentioned before, the standardized infection ratio, it's a summary statistic that tracks healthcare-associated infection and for the purpose of prevention and progress. Here's some information that I got from the CDC. So 0.92 is a national standardized infection ratio for C. difficile. The higher the SIR, the worse. The lower the SIR, the better. Okay, there was an increase, as you can see in this picture here, of 9%, which makes it bad. And this was in the state of California. Okay, so there's a 25% increase in the infections, okay? So for root cause analysis, hand hygiene. I identified hand hygiene as an issue. Lack of education to family and ancillary staff, mainly about PPI, like the use of gloves, the use of gowns, and proper hand hygiene. Late identification of C. diff infections, improper stool collection, like I mentioned, improper isolation techniques. So we're always taught, we always take the clean patient out. So if you have 2 patients, we have double beds in one room. So if you have a bed that you find that has a positive, you're going to send for C. diff because you suspect they have a C. diff infection. So before you send the stool, you're going to take out bed B, which is the clean patient, because that room is now considered infected. So you take out the B bed and then isolate a bed in that room. That's the proper way. And believe it or not, some people don't know that. Improper disinfection of surfaces, tools, and etc. I don't know how many times I see people go into the room, they use their stethoscope, personal stethoscope, to listen to the patient, and it's not disinfected. They do wash their hands, but then they grab that dirty stethoscope, which they're going to take for another patient. We also recently had a physician go in there without a gown. He didn't touch anything, but he did have his coffee in his hand. So he's drinking coffee in the C. diff isolation room, which is, I mean, hello. Ridiculous. So improper use of the PPI, like that physician, shouldn't be taking anything in there, especially not coffee. And he should be wearing gloves and a gown, even if he's not going to touch anything, because the room is infected. So I just put a little picture of what root cause analysis is. So there's the symptoms of the problem. You see a rise in C. diff. So you're going to go below the surface and kind of try to see what's going on, what can be causing this rise. So this is a report also from my unit. It's hand washing data for 2017. It's not only for my unit, as you can see, it's for all the units in the hospital. So I'm specifically focusing here on South 3 Heart Care Unit. We had a 56% compliance rate, horrible, of hand washing. Physicians had an even lower rate than that, 26% hand washing rate, leaving us at a whopping 41% compliance rate in hand washing, which is completely sad, you know, especially with isolation rooms. So we know that our increase in C. diff rates is definitely attributable to a decrease in hand washing. So what is the scope of the problem? So I got this article that I found in the New England Journal of Medicine called The Burden of Clostridium difficile Infection in the United States. So like I mentioned earlier, it's the leading cause of the gastroenteritis-associated deaths. This one estimates 14,000 deaths in 2007 alone just from C. diff. The most common cause of healthcare-associated infections in the U.S. hospitals is C. diff. Excess healthcare costs, approximately $4.8 billion. So from 2003 to 2007, it increased quite a bit, Now it's 4.8 billion in 2007. For acute care facilities alone, this doesn't include long-term care. There's also increasingly reported outside acute care facilities. So now you're seeing C. diff in the community and in nursing home settings. So C. diff surveillance, the CDC has this program called Emerging Infection Program. And this is where they base their data. This is where the C. diff infections are reported, and approximately 11 billion people are, studied. So the study findings, obviously they didn't do 11 billion people, but they found that persons greater than 65 years old who were white and females had a higher incidence of C. diff infection. They found that C. diff caused almost 500,000 infections in the United States in 2011. 83,000 people had a reoccurrence, and 29,000 deaths were found within 30 days of initial diagnosis. So who are the stakeholders? Honestly, I put this picture because I think everybody is affected by healthcare, but specifically acute care patients, because that's my focus, long-term care patients also, families, healthcare workers, physicians in the hospital. Everyone is a stakeholder. The patients, because they're the ones who have to undergo this horrible infection. The family, because they're putting themselves at risk. Everyone else, because we're taxpayers. We have to pay taxes on this stuff, Solution. So what is the solution? I put this huge picture in the back, unaware. So we want to educate. I think that that's a huge problem in my unit. We always were like, well, do we isolate? Do we send the stool? But they're on tube feeds. There's a lot of ifs and buts. So education with all the questions being answered for everyone all at once is important. Also, an antibiotic stewardship program. I have some data that I found on the CDC website with different studies that were done. So this one is Valaquette et al. The intervention that they did, guidelines for decreasing antibiotics use associated with Clostridium difficile infections. They created educational materials for physicians and pharmacists. They created recommendations to suggest alternative antibiotics for treating the different conditions. And they recommended shorter treatment duration for certain conditions based on Infectious Disease Society of America's guidelines. They found that there was a C. diff incidence decrease of 60% between 2003 to 2004 and 2005 to 2006. Total and targeted antibiotic consumption decreased by 23%, and there was a decrease in use of first-generation cephalosporins, which are known to cause C. diff because they're broad spectrum. So that intervention definitely impacted the results. Okay, the second one is by Muto et al. The study was done in an 834-bed tertiary care urban teaching hospital in Pittsburgh. They created educational materials for providers, establishment of active surveillance for C. diff. They expanded infection control measures with infection control audits, like observing hand washing trends, which is what my unit did. Well, my infectious disease person did. They targeted antimicrobial restriction, whereby clindamycin, ceftriaxone, levofloxacin, and other broad-spectrum antibiotics required ID and pharmacist approval, so like a double verification of the antibiotic to see if it was the proper one. So the impact, how did it impact Pittsburgh? So antimicrobial therapy associated with C. diff infections decreased by 41% from 2003 to 2005. Clindamycin use by 69% and fluoroquinolones by 54%. So there was definitely an impact, a positive impact. Aggregate rate of C. diff infections decreased from 7.2 per 1,000 discharges to 4.8 per 1,000 discharges from 2001 to 2006, and was 3 per 1,000 patients by 2006. So you can see the trend. It's going the right way. Additionally, hand hygiene, which is something that I definitely identified on my unit that was a problem, that is actually, I think, an easy fix. And we just have to wash our hands. Wearing PPI correctly, when to wear, how to wear, what goes in and out of the room. We have an issue also with trays. For a long time, the kitchen was sending plastic trays. They were being left in the nurse station, and then those trays are taken into the room when a disposable tray should be used, because then they take that tray out and put it along with the rest of the trays. So you have C. diff spores all over the place, and the infection spreads. So you want to clean with EPA-approved spore-killing disinfectant like bleach wipes. We have our bleach wipes that we're supposed to wipe with and leave for a total dry time of 5 minutes, which will get rid of the spores. Also, for the PPI, I want to mention, wearing gloves inside the room, it's important because you might not see the spores, but they're there. So decreasing the spores, touching your skin, being on your hands, you wear that second barrier, the gloves, you take it off, and then you wash your hands so you don't have those spores on you or with you. Because, you know, you might touch your nose before you get to the sink, or, you know, hit your pants, and then you have that bacteria on you. So solution implementation, what are we going to do? So for sure, flyers, hands-on learning education for all stakeholders that we can reach, you know, within reach. For us, we have health stream education. It's online education, online PowerPoints, online interactive videos, things like that, and review of policies. So we have an issue with C. diff. We're actually the second highest C. diff after MIC, then South 3, which is us. So bad. So the infectious disease nurse is coming around with a box, and she has clay-shaped stool, kind of like what you see here in the Bristol stool chart, showing us what the different stool is. So she states that diarrhea has to conform to the container. So it has to kind of get into the container. It can't be pasty and sticking to the sides, because that's not that true diarrhea. Okay, so that's something important, because we were just told if you can stick a toothpick in it and it doesn't move, then you don't send it. But I mean, sometimes you have that tarry stool that people actually have been sending down, causing our C. diff infection rate to go up like a false positive. They also put this diarrhea decision tree checklist all over the unit. So now this is what we have to do. We're going to review the checklist before sending stool samples for C. diff testing. Testing is indicated if there are 4 checked boxes. So the first box, is it loose, liquid, or watery? If it is, then you go down to the next one. If it's not, then you don't send the stool. Is it clinically significant? What is clinically significant? Has the patient had greater than 2 loose stools in 12 hours or 3 loose stools in less than 24 hours? Or if a rectal tube or ostomy was there, is it greater than 600 ml output in 24 hours? If it is, you go down to the next one. If it's not, you do not send. A lot of patients, okay, let's go to the next one and then I'll tell you. Has the patient taken any laxatives or had any procedures that induce diarrhea in the past 72 hours? If they do, you don't send the test, but you do discuss with the physician about holding those medications to see if it's true C. diff or if it's just that medication causing the diarrhea. Like lactulose, K-oxalate, we know, Colace. Next one, does the patient have accommodating symptoms of C. diff infection like a high fever, elevated WBC, abdominal pain, cramping, nausea, and vomiting? If you're uncertain, she provides her extension, so you can call her. For us, it's a little difficult because I work night shift, so she's not readily available. If it is, initiate contact precautions and then obtain an order to get a C. diff stool. So that's pretty simple, it seems like, right? But there's a lot of questions like, oh, is the patient on tube feed? You know that with tube feed, many times patients get kind of like that loose, that what might seem like diarrhea. So she was saying that with tube feed, you're not going to have more than 3 stools, continuous diarrhea. It's not expected. So if they are having those 3 stools and greater than 3 stools in 24 hours, then it's a concern for C. diff. So you kind of want to use some critical thinking there. So what are we going to do for analysis? We're going to collect more data, see if our C. diff rates have decreased, see we're going to be doing that by doing, well, not we, but, you know, the infectious disease nurse, our managers, etc. They're going to be doing chart audits to see our documentation, the medications that the patient on, if it was clinically significant to send the stool. And like I said, it's going to be like a second catch because we're going to be going through that checklist with our charge nurse to make sure that the stool is appropriate to send. Next steps. So what do we want to see? We want to see a decrease in the standardized infection ratio for our unit. So we want to be below 1. 0 hero is like our little saying that we say. You want to be 0 health care associated infections. You want to have none. But I mean, that's difficult. But you want to, your goal is going to be 0. You want to continue using protective equipment correctly, like using instead of using your stethoscope and disinfecting it, using the disposable stethoscopes, making sure you have your gown on correctly, making sure you change your gloves and you have gloves on at all times. Proper collection, like we talked about, the checklist, the stool checklist, and proper treatment of antibiotics. Also, we're going to see an increase in patient satisfaction because nobody likes having C. diff. They're uncomfortable. They're in isolation. Not everybody can get to them. It just doesn't feel good. And how we're going to do this, if it fails, if we have still an increase in C. diff, it's not kind of going where we need it to go, well, we're going to reassess and start again. So what is the problem? But that shouldn't happen. Of all the education that we're getting, I think that we'll be down the right road. And that concludes my presentation. Thank you so much for watching. Here are a list of my references. All right, thank you.